My name is Sundar Jagannath. I'm a professor of medicine at Icahn School of Medicine at Mount Sinai, New York. And on behalf of my co-authors, I'm pleased to go over the data on Linvoseltamab. This is a BCMA or B-cell maturation antigen-targeted T-cell engaging bispecific antibody. This induces deep and durable responses in patients with relapsed or refractory myeloma, including difficult to treat subgroups of patients. We know that bispecific antibodies are effective and treatment for relapsed and refractory multiple myeloma. There are currently 2 approved BCMA CD3 bispecific antibodies. One is teclistamab, another one is elranatamab. And this is a new bispecific antibody. It's a fully humanized IgG1 bispecific antibody. Here I will share the results of these patients who were treated on this study with a median follow-up of 11 months at the dose level of 200 milligram used in the Linker MM1 clinical trial, testing the safety and efficacy of Linvoseltamab treated patient in relapsed and refractory myeloma. So who are the patients who participated on the trial? These are patients with multiple myeloma who had progressed on or after 3 lines of therapy, including proteasome inhibitor, immunomodulatory molecules, and an anti-CD38 monoclonal antibody, or at least they were double or triple class refractory. And the patients received the drug intravenously weekly through week 14, then once every 2 weeks. And in those patients who achieved VGPR or better, they were treated for a minimum of 24 weeks, and then they transitioned to every 4 weeks. So they were getting weekly for first 14 weeks, then it became every 2 weeks. And then those patients who achieved VGPR or better after 24 weeks or 6 months, they were transitioned to once a month or every 4 weeks treatment. This will be important when we talk about the safety profile of this drug. Baseline characteristics are notable that almost 27% of the patients were older than 75 years of age. So the bispecific usage, especially in elderly and frail or intermediate frail patient, is much more safer than, say, CAR T-cell therapy in this population. So that's another added advantage of this. And this drug was given to quite a number of patients over the age of 75. 18% of the patient had ISS stage 3 disease, and 16% of the patient had extramedullary plasmacytoma adjudicated by independent review committee. So what is the importance of extramedullary plasmacytoma? This has been consistently noted to be as adverse risk, and even for CAR T-cell therapy, presence of extramedullary plasmacytomas is considered as high risk for the patient, or they will, relapse, or they won't do as well. So that's important for this group of patient. In terms of high-risk cytogenetics, almost 39% of the patient had high-risk cytogenetics. And BCMA is an antigen, B-cell maturation antigen expressed on plasma cells, but this is also released, cleaved and released from the surface. So you have soluble BCMA. Having high soluble BCMA is a surrogate marker for high tumor burden. Before we used to use beta-2 microglobulin, and then we told you about the ISS stage 3 high stage. But soluble BCMA is emerging as a tumor marker for high tumor burden. So in this study, quite a number of patients had high level of soluble BCMA, which is also important. So the median 50% of the patient had 368 nanogram per milliliter of BCM or higher. Then 82% of the patient had multiple myeloma that was at least triple class refractory. So triple class refractory is very important. I don't know, recently you might have attended the ODAC committee for the BCMA CAR T cell therapy for ida-cel. They showed that that is a population of patients who do extremely poorly in terms of overall response, and especially median PFS is extremely short in the group of patients. So having said that, Linvoseltamab, despite in this high-risk patient population, elderly patient population, the overall response rate was 71%, adjudicated by independent review committee. And more important is 46% of these patients were in complete remission. And among the patients who were in complete remission, when we tried to determine the MRD status of the patient, by clonoSEQ, which is FDA approved, what we call as, one of the way to monitor the patient. And the other one is by flow cytometry using Euroflow. They are all sensitive to 10 to the minus 5, and actually clonoSEQ is even sensitive to 10 to the minus 6. And you find out that 93% of the patients were MRD negative, which is very, very impressive in those patients in CR when they did determine the MRD negativity state. So the high response rate was seen in all the different subgroup of patients, even patients over the age of 75. The response rate was 71%, which is very impressive. ISS stage 3 patient overall response rate was 62%. And the high-risk cytogenetics, the overall response rate was 67%. And African American patients also responded very well. Overall response rate was 85% in the subgroup. And you have to know that the high disease burden subgroup with bone marrow plasma cell greater than 50% and soluble BCMA greater than median, even those patients had very high response rate. So across the subgroups, the treatment, this drug was effective. And there is, if you look at this, there is a swimmer plot. If you look at the swimmer plot, it shows that there is deepening of response over time. The median follow-up is 11 months, but you will see that there is deepening of response as the patients stay on this particular study. The median duration of response was not reached among the 83 responding patients at the 200 milligram dose. And all treated patients to the full dose of 200 milligram. The median progression-free survival was also not reached, with a median follow-up of slightly under 12 months. And at 12 months, the median progression-free survival was 69%. And the median overall survival obviously is not reached, but the follow-up is still short. Treatment emergent adverse reactions for this class of drug, bispecific and CAR T, is so-called CRS, because when you stimulate the T cells to fight against the myeloma cells, they do that by releasing cytokines. So they release cytokines, and this cytokine release syndrome includes fever, and low blood pressure or some neurological confusion, etc. So that's important. So the most common side effects are CRS, neutropenia, and anemia. Infections is another important component. Infection occurred in 73% of the patient, with grade 3-4 infection noted in 34% of the patient. This is also known for this class of drugs. Treatment emergent adverse event leading to death within 30 days of the last treatment dose was reported in 6 patients treated at 200 milligram. 5 of these were due to infection, and 1 was due to renal failure. The CRS occurred in 46% of the patient. 35% of the patient had grade 1 CRS, 10% had grade 2, 1 had grade 3 CRS. And the median time was about 11 hours. Median duration was 14.8. Because of this drug is given, IV, and only during the first two step-up doses, the patients are expected to stay in the hospital for 24 hours. So then they are released. So hospitalization with this particular drug is very brief. That is another unique uh, mm, property of this drug, the way it is administered in the step-up dose and the duration of hospitalization. And the infection, as I told you, the first 14 weeks they get it weekly, then everybody transitioned to every 2 weeks. And then those patients who are getting VGPR or better, they are all transitioned to every 4 weeks. So if you look at the grade 3-4 toxicity, from 20% during the first 6 months or so, it drops to 4 to 5% range after 6 months. So this shows that by reducing the dose, the frequency of infection goes down, so the safety increases. And we are reducing the dose for patients who have gotten the maximum benefit, that is the VGPR or better. So as the deepening of response happens, the safety is improved by reducing the frequency by protocol design, and still it is sustained. As you saw, the median progression-free survival was not attained. That's very unique design for the study and to show that it is by reducing, they have not lost the efficacy.